Hello everyone and welcome to the Oral and Maxillofacial Surgery webinar series. We are very excited to begin this new specialty series with you and to explore some of the key topics in oral and maxillofacial surgery together. My name is Omar and I am the webinar director at the SCORE committee. It's a pleasure to have you all with us today. Before we begin, I would like to briefly introduce the International Association of Dental Students, IDS. IADS is the largest global representing the students worldwide, connecting students from different countries and creating a platform for academic exchange, professional development, and cultural collaboration. The webinar series is organized under the SCORE Office of IADS. SCORE stands for the Standing Committee on Research Education, and it focuses on research education. Through core initiatives, students have the opportunity to engage with experts, participate in global projects, and gain valuable learning experiences. We hope you will find today's sessions and the upcoming webinars in the series is insightful and beneficial. It's a great pleasure to welcome Dr. Safa today, and we sincerely thank her for sharing her expertise with us. To introduce our speaker and guide us through the session, I would like to hand over to my colleague Adham.
Hello, everyone. Dr. Safa. Dr. Safa is an oral and maxillofacial surgeon. She is currently a research assistant and teaching assistant at the College of Dental Medicine, graduated from the Faculty of Dentistry, University of Gezira in Sudan. She obtained a clinical master degree in oral and maxillofacial surgery from Khartoum University in 2017. She is a member of the Joint Dental Faculties in UK, MGDF, and a fellow of the Royal College of Surgeons in Ireland. We hope you enjoy today's webinar.
Assalamu alaikum rahmatullah all, and thank you so much for the nice introduction, Adham, and thank you also for Umar and all the rest members of the IADS. So shall I start now sharing my slides?
Yes, doctor.
So for today, we can start now. So for today, we will be speaking about odontogenic tumors. And what is really very important about this topic is that the undergraduate students, they do not need to know that too much information about odontogenic tumors. But today we will start to go through the most like common tumors which are occurring, and maybe we can also give insights about their signs and symptoms and how we would appreciate examining our patients who are coming complaining of things which are related to these tumors. So as an introduction, we have to differentiate first between tumors and cystic lesion. And I would say that I think you all appreciated that the cystic lesions are cavities which are containing fluids, while tumors are soft tissue, mainly extensions or growth in specific areas within the oral cavity. As well as we can add that on our examination, while we are examining such lesions, we might differentiate between them that the cystic lesions, when we palpate it, it will look more fluctuant because of the fluids which are within the cavities, While for the tumors, we might see that on palpations, the consistency of the tumors, it gives us the nature of there is something which is firm. So generally, we can define tumors as growth of abnormal tissues in the body. And also this can happen within the oral cavity, because today we are mainly focusing on the oral cavity. And also we are all aware about the broad classification for the tumors, that they are divided into benign tumors and malignant, given the behavior of the cells within this tumor themselves. For example, we would appreciate all of us that the benign tumors, they have the nature of growing slowly and being encapsulated within a specific area, while for the malignant tissue, they are always very invasive and they are having a nature of fast growing, as well as they do have the feature of metastasize, either locally or with distant organs or structures. And also we have divided these tumors into benign and malignant, depending also on the cellular structure itself from the beginning. So within the cells, we might see that there are features that might indicate that there are dysplastic changes or cancerous changes within these cells. This is given the fact when we examine the tissues under the microscope. And when we speak here about the area of focus for today's lecture, which are the jaw tumors, the tumor that we will see inside the oral cavity, they are divided into two broad categories. Apart from that, they are malignant or benign. We have to speak about the big category here for the oral cavity tumors, which are odontogenic tumors and non-odontogenic tumors. For today, I will just focus with odontogenic tumors. And when we say odontogenic tumors, here we are trying to describe the tumors which are originating from the tooth forming apparatus, which is here. If we went back through the development of the tooth structure itself, we would appreciate that there are some stages that the tooth might come through until we can see the fully dentition, which is erupting in the oral cavity, like the body stage and the belly stage. And we would also remember that during these early stages of development, we have some cells which are related to epithelium and some cells which are related to ectomesenchyme. Then the induction and the proliferation between these and the reaction between those two structures will give us a specific structures. Here, when we speak about those early stages and when there are any like aberrant proliferation or inappropriate growth within those tissues at that stage, this might lead to those odontogenic tumors that we are speaking about. And if we are trying to classify those odontogenic tumors, we might give them three types of classification. So it might be we are speaking about the tumors which are arising from the epithelium, as we said, and it might be mixed between the epithelium and the ectomesenchyme. And also there are tumors which are originated only from the odontogenic ectomesenchyme. Now, looking at this table, the classification might be a little bit complicated. And for example, how will the undergraduate just be like very clear and how to differentiate about the origin of these tumors? Given the fact when we speak about the odontogenic epithelium, I will just try to give tips and tricks for this one. Like, for example, when we are speaking about tumors which are originating from the epithelium, here definitely we are speaking about the epithelial layer within the oral cavity. And some of these tumors are the ameloblastoma. When we now, within my upcoming slides, we would see originally where are they coming from. So ameloblastoma, which is coming from the oral mucosa, this one is considered as an epithelium tumor. And also, along with that, clear cell odontogenic carcinoma, adenomatoid odontogenic tumor, and calcifying epithelial tumor, as well as squamous odontogenic tumor. Now, no need to put all of this in your mind. Just I want you to focus within two, because these are the two that we will be discussing through today's lecture, which is ameloblastoma and adenomatoid odontogenic tumor. Moving to the second category, which is we are speaking about mixed odontogenic tumor. Here we are speaking about tumors which are originating from the epithelium as well as from the ectomesenchyme. And given this fact, we will see that those tumors, they are having mixed name even. For example, you will see that it is ameloblastic fibroma, which is here we can see the oral mucosa itself along with fibrous tissue. And also you will see ameloblastic fibrodontoma, ameloblastic fibrosarcoma, and the most important one here is compound odontoma. This we will speak about it, inshallah, through the thing that I will be discussing, compound odontoma and complex odontoma. Now, coming to the last classification, which are tumors which are arising only from ectomesenchyme, we would appreciate here the fibroma itself. We are speaking about odontogenic, but it is mainly fibroma, and we are speaking about granular cell odontogenic tumor, odontogenic myxoma, and cementoblastoma. Mainly within my lecture, I will be covering only the odontogenic myxoma from these types of tumors. This table is also showing the latest WHO classification, which was done in 2017, and it is showing the same thing related to the classification, given the fact, as we said, that there are three main origins for those tumors to come from within the oral cavity. Either they are coming from the epithelium, either they are coming from the ectomesenchyme purely, or even they are mixed from epithelium and ectomesenchyme. Now moving to the first tumor that we will be covering for today, which is ameloblastoma. This is one of the commonest tumors that are occurring within the oral cavity, and it might arise. As we said, there are so many theories and there are so many studies which have been investigating the origin and where are they coming from exactly within the tooth forming apparatus. So some they have suggested that the epithelial, the rest of dental lamina, and also they might arise from the enamel organ. This also give it the name as ameloblastoma. And also it might be arising from an epithelial lining of an odontogenic cyst. And we will see that when we come to the radiographic features of it, we might see that there is one type of ameloblastoma. It does have the same feature as a dentigerous cyst. That's why some people, they might suggest that it's coming from an odontogenic cyst, or the last origin for it, it might be the basal cells of the oral mucosa. Now, looking to all these origins for the ameloblastoma, we would appreciate that they are all related to epithelium. That's why it is a purely epithelium tumor structure. Now, about the features of this tumor, it might be slow growing, but it is locally invasive tumor. And also, given the fact that it is locally invasive, also it is one of the benign tumors which are occurring within the oral cavity. There are three different clinical radiographic situations for this tumor. We might see it as a conventional type. They call it conventional solid or multicystic, and this is the last percentage for them to occur, which they represent like 86% of all cases within the oral cavity. And also we might see the unicystic carcinoma, which is a little bit rare, about 13% only from the cases, and the peripheral one, which is even more rare, which is related here to the gum structures or within the gingiva. We might see it as an extra osseous presentation for the ameloblastoma. Now, moving to the first type, as we said, the conventional type of ameloblastoma, they call it also the solid or multicystic ameloblastoma. This is definitely, it's an intraosseous lesion, and we will see it mainly in the posterior mandible. If we are speaking about the age here, we would see that the different, the patients who are presenting with these tumors, they are within their third up to the 7th decades of life, and males and females, they are affected, both of them similarly, but here some studies, they have found that most of the patients who are affected by this ameloblastoma, they are from Black, and others, they show that there are no any racial predilection. So the sites, as I mentioned, 80 to 85% of this ameloblastoma, they are occurring within the mandible, and specifically within the posterior part of the mandible. Here, mainly, we are speaking about the molar ascending ramus. About 15 to 20%, they might occur within the maxilla. And also, if it happens within the maxilla, then here also it is in the posterior regions. How this tumor will present to us when we are examining the patient, we will see that there is a painless swelling or expansion of the jaw, and sometimes, or most of the time, it is asymptomatic. Sometimes only during radiographic examination, we might be able to discover it. And also these lesions, if they are left untreated, the lesion may grow slowly to very massive and grotesque proportions. And also it might cause facial disfigurement. Now, given the fact this tumor, it affects the posterior part of the mandible and it might reach to a very large size, regardless of this information, the idea is that the patient will not suffer from any paresthesia within these tumors and also pain. So it's always a painless swelling unless it gets secondarily infected. This is the distribution for the percentages that I have shown earlier. We said that most of the lesions, we would see them within the posterior mandible, in the posterior area of the molars or ascending ramus. And within the anterior area, we see that the percentage is very less. And also, if we are speaking about the maxilla, we would see that also the preferable site for it is the posterior maxilla. Now here are some clinical pictures for patients who have been suffering from these lesions and with different sizes. Yani we can see here at the first one on your right side, you will see that the tumor, it is located at the posterior part of the mandible. And here the tumor size is a little bit of moderate size, we can say. Here is an ameloblastoma, which is involving the anterior part of the mandible. And this one, it is involving the anterior as well as the posterior because it has been maybe neglected for a very long time and the patient did not seek the medical help. That's why there is facial disfigurement, which is very obvious. We can see it here in this patient. Those are again some photos which are showing ameloblastoma. And I will just focus on this one. We can see that the tumor will grow, yes, slowly, and it is very invasive. But the idea is that we will see displacement and floating of the teeth which are surrounded by the tumor. But the idea is that when we examine the patient, we would see that there is a buccolingual expansion or a labiolingual expansion for the tumor. If we are speaking about the anterior area, the same will happen within the posterior area. We will see the buccolingual expansion of the tumor because the tumor will invade the bone and it will cause a very big swelling on that area. And we'll see that the adjacent teeth will be having mobility, which will be like a very severe mobility, and sometimes the tooth might be lost because of the tumor. Now, looking at the radiographs, how we would see these tumors in the radiograph, sometimes they might appear as soap bubble appearance or they might appear as honeycomb appearance. Now, what is the difference between those two radiographic features? At the beginning, we have to recall that the lesions within the radiograph, we are always describing them as radiolucent when there is like the dark colors, and radio-opaque when there is the white color, which indicates mainly the calcifications. So when we are speaking about the radiograph for this ameloblastoma, we will see that the lesion will appear as soap bubble appearance. We will see that as if there are circles which are attached to each others. And when we say honeycomb appearance, they appear mainly as squares and they are perpendicular to each others. So they look similar to the honeycomb. Now, when these tumors are excised or even a biopsy is taken from them for the histopathology, in the histopathology, they have, in terms of histopathology, they have identified 6 main types of ameloblastoma under the microscope. And the most common one, they are the follicular and plexiform. And I have attached some photo for them just for you for reference. The rest are granular, acanthomatous, and desmoplastic, as well as basal cells. But the most common one, they are the follicular, which is here, we would see that it looks like follicles, and the plexiform, which is here shown in the bottom slides. Now we spoke about ameloblastoma, where is it? And where is the origin for it exactly? And how does it present? How would see it in our patients clinically and how, what we will see on the radiograph? Coming to the treatment, we have to know that the treatment is also like having a wide range. So for example, it depends on the size of the tumor itself. If it's a very small size, we can go for the simple inoculation. It might be as well associated with curettage, and it can be progressing even to do in-block resections, which is marginal resection. I will show this in the upcoming slide, as well as it can be a complete resection of the mandible itself. The recurrence rate is very high, especially when we went to the conventional treatment methods. So if we went for the inoculation and the curettage, we would anticipate that the patient, they are having the likely of 50 to 90% for the tumor to recur again, while within the marginal resections and the complete resection of the tumor, the recurrence rate will be less, up to 15%. The idea is that we have to stress and have like a stop here on this information, that the margin of the resection, it should be at least 1 to 1.5 centimeter past the radiographic limit of the tumor. And the idea is we are having these safety tumors as if we are treating this tumor as a malignant tumor. This is all to avoid the idea of the recurrence and to avoid leaving any cells of the tumor within the bony cavity. The idea also about the resection is that the resection for the tumors within the posterior maxilla, it will be a little bit difficult, because the posterior maxilla, it does have a continuation within the cranial base. That's why having like a clear margin about this 1 centimeter or 1.5 centimeter, it will be a little bit difficult when we are speaking about tumors or ameloblastomas which are occurring within the maxilla. This diagram, it's showing the idea of the in-block resection. So when we are speaking about the tumor which is not having that big size, we might go for the marginal mandibulectomy or the in-block resection. Sometimes when the tumor is very large, like the photo that we have shared earlier, we might go for the segmental mandibulectomy. And even, by the way, if the ramus of the mandible and even the area of the chronoid process here, the condyle itself also is affected, we might go for this articulation. This radiograph, it is showing that this is the tumor which is starting here at the posterior area. And we can see that here part of the tumor, it is invading, or it is near even to the condylar process, and chronoid process is already eaten by the tumor. That's why for this patient, they did removal for the full tumor, plus this articulation for the joint. Here, the idea is that don't think that those patients, they will be left. There are other methods for reconstruction, and maybe you might study them later, but this area will be reconstructed, and there are also prosthetic joints that can be placed for such patients. Now, moving to the second type of ameloblastoma, which is unicystic ameloblastoma. We spoke earlier about the conventional type. Now, this type, which is called unicystic ameloblastoma, it is given like a separate consideration because the clinical and the radiographic features, they are a little bit different from the first type that we spoke about, and also given the pathological feature for them. They are accounts, as we said, for 10 to 46% of the intraosseous ameloblastoma. And also, sometimes there might be some neoplastic transformation for them. And this is an area of debate, but there are some cases which have been transferred from unicystic ameloblastoma to ameloblastic carcinoma. Now, the age for the unicystic ameloblastoma, it's often seen in younger patients compared with the conventional ameloblastoma, which is seen in older ages. And also about 50% of these tumors, they are diagnosed within the second decades of life. The average age, if we are speaking about unicystic ameloblastoma, is 23 years old. The site, definitely it will be the posterior mandible. Again, 90% of the unicystic ameloblastoma, they are found within the posterior mandible, and usually it occurs within the posterior region. For the clinical features, we would see that the large lesions, even, they are not symptomatic. That's why they are mainly discovered only through the accidental discovery, on radiographs when we do them for the patients, for routine examinations, Within the radiographic features, if you take a look now, you would see that it is definitely different from the first type that we have seen, because that one was shown as soap bubble appearance or honeycomb appearance. Here, no, we would see it is like as if it's a cystic lesion, a very big unilocular radiolucency. That's why they call it as unicystic ameloblastoma. So it appears as a circumscribed radiolucency that surrounds a crown of unerupted mandibular third molar. And clinically, it resembles a dentigerous cyst. So when we examine the patient, we might have a feeling, or one of the differential diagnoses that we might put for such patients, dentigerous cyst and unicystic ameloblastoma, they are always look similar in terms of clinical examination and in terms of radiographic features. Even when we spoke about the impacted third molar, which we can see here, we can appreciate it here in the first radiograph as well as the second one. So the radiolucent area, it might have scalloped margins, but it is still a unicystic ameloblastoma. You might see here, when we speak about this one, we can see that the margins, they are scalloped. The diagnosis of ameloblastoma is merely is made only after the histopathological or the microscopic study of the specimen. So as I said, when we examine the patient, we might be even confused between both of them. But then the result of the biopsy will terminate that doubt or that debate. This is again one of the radiographic features. We can see it here on a CT scan. You can see that it's all appear as one cystic lesion. That's why they call it unicystic ameloblastoma, or they name it as, we said, as unilocular radiolucency. The treatment will be definitely by inoculation, and the recurrent rates, it's from 10 to 20%. And this, given the fact, after even doing the inoculation and curettage of the unicystic ameloblastomas. And for these lesions, why did they went for the inoculation mainly and the curettage? Because it does look similarly as a cystic lesion. This is the first thing. And the second thing is that when we look at the margin of the mandible, we would say that a larger portion of the mandible will be taken if we are seeking the resection. And given the fact that this unicystic ameloblastoma compared with the conventional one, it is not that invasive at the first type. Now moving to the last type of ameloblastoma, which is peripheral or extraosseous ameloblastoma. Now they call it as extraosseous because we would see the tumor growth outside the bone. And this type of tumors, they are rare. They might be account only for about 1 to 10% of ameloblastomas. They arise, as we said here, we would say mainly from the dental lamina beneath the oral mucosa, or from the basal epithelial cells of the surface of the epithelium. You might see that there is a tumor here, which is at the area of the marginal gingiva. But then when we do the examination, you see that the tumor is a little bit firm, which can help us in differentiating it from other types of lesions which might occur at these areas. The treatment is definitely by local surgical excision because we don't have that bony invasion, and we do not have any intraosseous lesion which is available there. Now moving to the second tumor, and before moving, I would just recall again the information that I have said. We spoke about the first tumor within the epithelium part, which is ameloblastoma, and we said that it's a tumor of posterior part of the mandible, and even if it happens in the maxilla, it will occur on the posterior part. We spoke about that. There are 3 types of it, clinically and radiographically. The first type is the conventional type. This is the common type. And then we spoke about the unicystic ameloblastoma, which can be differentially diagnosed with dentigerous cyst. And we spoke about the last type, the extraosseous one, or the peripheral ameloblastoma. Now moving to the second epithelium tumor, which is called as calcifying epithelial odontogenic tumor. This tumor is also called as Binborg tumor, given the name of the scientist who discovered this tumor. Now this tumor, it does look the same, by the way, as ameloblastoma. The only difference is that we might see these calcifications along with the multilocular radiolucencies, which are in the posterior part of the mandible. So mainly, we would see radiolucencies with driven snow classifications. We would say that there are some classifications which are scattered at the area of the tumor within the radiograph. And then when we took the area for biopsy, and I mean here, of course, incisional biopsy, because guys, for these tumors, all these tumors that I'm speaking about, we have to take an incisional biopsy first, just to discover the nature about the lesion that we are speaking. And then after that, we might decide the treatment which is suitable for that tumor or for that lesion. So for this tumor, which is calcifying epithelial odontogenic tumor, when we take the biopsy, we would see that there are amorphous pink amyloid with concentric classifications. So again, the concentric classifications, even within the histopathology, we will see them. And then they have the specific name, which is Lezy gang. So guys, try to put that in your mind that Lezy gangs are pathognomic for epithelial odontogenic tumor or Bindborg tumor within the histopathology. And the treatment is definitely by surgical excision, similar to ameloblastoma. Now, moving to the adenomatoid odontogenic tumor, the third tumor, which is arising from the epithelium as well. Here, the origin for this tumor is from the enamel organ epithelium or the Hertwig epithelial roots. Now, when we say adenomatoid odontogenic tumor, we are speaking about a tumor which is look like epithelial duct-like. And here, this is indicated by the starting of the tumor or the initiative, which is adeno. So adenomatoid odontogenic tumor, it's a tumor which is like duct epithelium, and then it is arise from the enamel organ. The investigators, they have tried to like collect some information that might be used to properly describe this tumor. So this tumor have been described after several studies as the tumor which is associated with canine, and the tumor which is mainly happening among females more than males, and also it occurs within the second and third decades of life. So because all of the measures for this tumor and the numbers which have been identified, it is like 2/3. So sometimes they might name it as the 2/3 tumor. So this tumor, it represents 2/3 of the tumors which are occurring within the oral cavity. And also 2/3 of the tumors, they are associated with canines. That's why the adenomatoid odontogenic tumor, most of the times we will see it in the anterior maxilla, at the area, as we said, of canine. And also it occurs, the patient that will have it, 2/3 of them will be females from the cases, and also it is occurring within the second and third decades of life. So those information, they might put it in your mind that when you are taking the history from your patients, collecting the information, and also like trying to integrate them together, you might reach the differential diagnosis of adenomatoid odontogenic tumor, given the fact, for example, if we are saying there is a patient who came or who was referred to your clinic, for example, her age is 11 years old, and then she's having a swelling on her anterior maxilla, and then she is a female, of course. And then when you took the radiograph, you would see that the tumor is associated with an impacted canine. That's why we said that it is associated with impacted canine. So guys, always within these such types of information, try to collect the information and to integrate them in a manner that when a patient presented to you, you can just give the differential diagnosis, and you might give them like the appropriate referral in cases of that you will be referring the patients to the specialist. Now, how does this tumors clinically and radiographically appear, having the appearance of? For these tumors, as we said, the age is between 10 to 19, which is the second and the third decades of life. And also they have a striking tendency, as we said, to occur in the anterior portion of the mandible within the area of canine. Those informations, they are repetitions for the previous slide. As we said, the females, they are mostly affected, and frequently the tumors are asymptomatic, and they are discovered also during routine radiographic examination, especially when the patient or the parents, they are bringing their child because of an unerupted canine. Large regions might cause resorption within the bone, and we might appreciate that within the radiograph. So within the radiographs, as we said, 75 of the cases, the tumor will appear as a circumscribed unilocular radiolucency involving a crown of unerupted tooth, which is most of the time in the canine. And then it may be difficult to differentiate also between adenomatoid odontogenic tumor and dentigerous cyst, because all of us also, we know that dentigerous cyst is also a cyst which is surrounding an impacted tooth. And here we do have the impacted canine. One of the things that might help me differentiating between them is definitely sometimes within these tumors, adenomatoid odontogenic tumor, we might see also calcifications here along the area of the radiolucency. And plus, definitely, the histopathological report will give me the exact diagnosis. The treatment is by inoculation. Now here we are showing some cases which are having this tumor as well. Here we are speaking also about the adenomatoid odontogenic tumor. We can see that it's a circumscribed radiolucency at the area of the canine, and here we can see the impacted canine. Here, this is one case which have been treated by inoculation. This is the preoperative radiograph, which we can see here the impacted crown within the lesion, and then here the lesion after removal. We might see that the lesion is fully removed along with the impacted canine itself, and here this area might represent the classification that we spoke about, and also it looked like ducts here. Those are the ducts for the epithelium. The last and the definitive diagnosis, we will give it after doing the histopathological report and after reviewing the biopsy under the microscope. Now, within the histology, we would see the duct-like pattern that we spoke about earlier in a very clear manner. So that the epithelium, they will appear as columnar epithelial in duct-like pattern cells. This is how the adenomatoid odontogenic tumor will look like under the microscope. Now, it seems we have covered all the common odontogenic tumors which are arising from the epithelium. So far, up to this moment, I have covered the ameloblastoma with the types of it, and we covered the calcifying epithelial odontogenic tumor, as well as we covered the last one, adenomatoid odontogenic tumor. Now, moving to the tumors which are having mixed origin, which means they are originating from the ectomesenchyme plus the epithelium, we will talk about odontoma. This is the most common benign mixed odontogenic tumor that might occur within the oral cavity. And I'm sure most of you, especially those who have started treating patients, they might discover some of these types of odontomes while they were treating their patients. So when we speak about odontoma, we are speaking mainly about, as we said, the tumor which is occurring maybe within the posterior part of the jaws or anteriorly, depends on the type of the odontome themselves. And when we say odontoma, we are speaking about developmental anomalies which are affecting the teeth themselves. So we see that there are abnormal structures, but they are tooth-like structures which are impacted there within a specific area, and also they might like disrupt the normal eruption of the adjacent structures. So when we are speaking about types of odontoma, we might say that compound odontomas, which are composed of multiple small tooth-like structures. So the compound odontoma, we would see that the structure, they look like the normal tooth structures. They might be a little bit small, but the same structure as the itself. While the complex odontoma will be a conglomerate mass of enamel and dentine, which is look like a very big radio-opaque mass located mainly within the posterior area. And it does not look like the tooth structure exactly. So if we are trying to differentiate between compound and complex odontoma, we will differentiate between them in terms of shape, which is for the compound, we said that the structures will be look like tooth structures of small sizes, while the complex, no, it is just enamel and dentine, like in a very circular and large structures. And when we spoke about the site for them, compound odontomas, they are always occurring at the anterior part of both mandible and maxilla. While for the complex odontomes, we will see them mainly in the posterior part, and I will show some radiographs for this one. As we said, it's one of the most common odontogenic tumors mixed that can occur within the oral cavity, and it is also occurring during the first 2 decades of life, and the mean age is 14 years. Again, here, the main complaint that might bring the patients for the clinic is that there are some teeth which are not erupting yet in the oral cavity. The clinical pictures, they are always asymptomatic and always will be discovered within the routine radiographic examinations, or the complaint will be that there are some teeth which are not erupting or missed teeth within the oral cavity. They are relatively small, as we said, and they seldomly exceed the size of the normal tooth, because normally they are smaller in size. However, large odontomes, which is here we are speaking definitely about the complex type, they might reach up to 6 centimeters or more in diameter. And those types of tumors, they mainly occur within the posterior mandible. And if the size reaches up to this 6 centimeters, we might see that it might cause expansion of the jaw. As we said, they occur mainly in the maxilla more than the mandible, but also in the mandible, there are some reported cases of odontomes. This is also a repetition for all what we have said, that compound odontomes, they look like tooth-like structures. They vary in size and shape. And for the complex, they are like calcified, very large masses, and they might be associated with an eruptive teeth. Here it is very important to mention that there is one syndrome which is associated with multiple odontomes as well as other features, which is Gardner syndrome. So Gardner syndrome is a very important syndrome, and we have to know about it. Sometimes there are even international which are asking about the syndromes which are associated with multiple odontomes, and there are other features which are associated with these syndromes, like the colorectal carcinoma and interstitial polyposis. We have to be very sure about what are the other features which are associated with such syndromes. Here, if we are taking a look, we can see that there are some tooth structures which are here, and these tooth structures, we can see that they are causing the impaction of this canine. So the canine will not erupt normally unless we remove this part of the odontomes. Here is one part of the structures themselves, they have been removed surgically. And here we are speaking about an odontomes which is of a very large size, up to this maybe 4 centimeters, and it is located here within the posterior part of the mandible. So looking at the side itself and looking at the shape of the odontomes, we might be able to differentiate between the two types. So are we speaking about a compound odontome or a complex odontomes? I'm sure that looking at the radiograph and looking also at the side of it, you might be able to tell the type and the origin for the odontomes. No, I mean the tooth which are affected by the presence of these odontomes. So looking at the radiograph, you might tell, is it one of the differential diagnoses might be odontomes. You might tell the type, and also you might take a look at the effects, which teeth have been affected by the presence of these odontomes. The treatment, as we said, they have to be excised, and the prognosis is very excellent because there is no any recurrence rate. And the idea is that they are always removed for the sake of the ease of eruptions of the impacted teeth. So it's always having a very good prognosis, and most of the time the teeth which are impacted, they might come into like a normal occlusal position. Now moving to the last tumor, which is here, this tumor is purely arising from the ectomesenchyme. Now we are speaking about odontogenic myxoma. So from each type of the tumors, I tried to pick the common type that we can see within the oral cavity. And then after that, the rest you can like just integrate them together, because like, for example, given the fact, even the tumor, it will be like a different type, not the type that we spoke about. At the end, we have like known the general information about the tumors, how do they present, how we differentiate them, and where are they occurring in patients, and how would the patient come to us? What is the main complaint that the patient might come to the dental clinic? Now moving, as I said, to the last type of tumor, which is odontogenic myxoma. This is a purely ectomesenchyme tumor, and sometimes they might call it as myxofibroma because it is a mixture between because it is an ectomesenchyme, so sometimes they might call it as myxofibroma. The clinical features, they appear in young adults, and it might occur across a very wide age group. The average age for the patients who are presenting with these myxomas might be 25 to 30 years, and there is no any sex predilection. We might see it in females as well as in males. Most of the time, the area which is affected mainly are posterior mandible. It might be also seen in maxilla, but most commonly in mandible more than the maxilla, and most of the time also within the posterior part of the mandible. So smaller lesions might be asymptomatic, and they might be also discovered during routine examination, radiographic examination, I mean. But the larger lesions will be a painless expansion of the jaw, and the patient will present with painless tumor. So one of the things that we might put in our mind that painless tumor within the posterior maxilla, and after doing the clinical examination and asking for the radiographs, we have to specify the differential diagnosis. So a differential diagnosis for a tumor which is occurring within the posterior mandible, first of thing that ameloblastoma should come in our mind. The second thing is calcifying epithelial odontogenic tumor. And I would say that odontogenic myxoma also might come as one of the differential diagnoses. And in some instances, the clinical growth of the tumor might be very rapid, and also it might lead to facial disfigurement. Within the radiographic features, we will see that it appears as a unilocular or multilocular radiolucency. It depends on the size of the tumor itself. So it looks similar to ameloblastoma within the radiograph. Also, the margins of it might be irregular or scalloped in their shape. And large myxomas of the mandible might show a soap bubble appearance. And also it might appear, by the way, as a honeycomb. So that's why I told you for tumors within the posterior mandible, try to organize yourself to put which come first in the differential diagnosis. And this also, it depends on whether you have an impacted tooth on that side. Are we seeing a scalloped margin? Are we seeing some calcifying flakes on that side? Then you can arrange the list of your differential diagnosis. Now here are some part of the regions, which we can see it here at the posterior part, multiple radiolucency. And then here, this radiograph, it's showing the lesion after the excision of it. And here you can see that there is a reconstruction plate, which was placed just to maintain the continuity of the mandible. And this will take me back to the point that I have mentioned earlier, that the tumors that will be removed, they will be replaced, and there are so many replacement and reconstruction options for the removal, after removal of tumors. It depends on the size of the tumor as well as the location and so many other features. I think discussing the reconstruction and everything, that will be like a separate topic, not the topic for our today. Now, looking at the histology for a myxoma, we will see that in the histopathology, it will look like spindle cells surrounded by mucoid material. And this is why they call it as myxoma. They call it as myxoma, given the fact that it arises from a mucoid, or there is a mucoid material which is involved in the histopathology. For the treatment, it depends. Always the small tumors, they are treated with curettage, starting from the ameloblastoma itself, or it might progress to resection depending on the size of the tumor as well as the location, where do we have it exactly. Now, the take-home messages from these slides, that the odontogenic tumors, they might be common and they might be uncommon. But the idea is that early recognition is very important. And the starting point always for the early recognition, by the way, is the general dental practitioner, because he is the person that the people are following themselves with him. So whatever there is anything which is discovered, you might think that you are in doubt of anything, it's better to refer the patient because early recognition is always better for the patient, given the fact the treatment plan, the destruction that might happen to the patient after the procedure, everything will be less, and maybe he might go, they might take him, for the non-invasive types of treatment. The odontogenic tumors, we said that the types that we spoke about, they are all benign. But given the fact they are benign, but they are locally aggressive if left untreated. In terms of radiograph, and we might see that in radiographs, they might look the same, because as we said, now ameloblastoma, calcifying epithelial odontogenic tumor, as well as odontogenic myxoma, they might look the same. What will tell us more about them is biopsy and histopathology. So the definitive diagnosis will come only after doing the biopsy. This is the most important investigations in terms of differentiating different types of lesions which are presented intraorally. They need referral, yes, of course. So whenever you are suspecting something, you have to refer them for a maxillofacial surgeon. And the idea is that why do you need to know all these informations? Because you have to write a proper referral letter. So writing a proper referral letter will necessitate that you have to examine the patient. You have to say what were your positive findings during examination. First, طبعا, we start with the history of the patient, and then you will move to the examination, and you have to mention the differential diagnosis before referring your patient to the specialist. Again, one of the very important messages that we have to put in our mind that secondary infections might occur within the tumors, and this will give us the nature of pain. If you remembered all the tumors within their clinical presentations, we have said that they are painless swelling, but they will be painful in case of secondary infections. And again, secondary infections as well, they might obscure the true nature of some lesions. So sometimes if we took a biopsy from an infected lesion, by the way, we might not be able to identify the exact diagnosis. That's why it is always, and it is most of the time, recommended that infections should be treated first with giving antibiotics or drainage, and then after that we can take the biopsy. And the last thing is that given the fact that those tumors, they have local recurrence, it might be for after a very long time. That's why they need long-term follow-up. So the patients who are being treated from odontogenic tumor, we will not say that they are free from tumors and they do not need any follow-up. No, we will follow the patient, and sometimes those patients, after receiving their treatment, they might come to your clinic for the regular follow-up. You have to keep an eye. If you did see any signs of recurrence within your routine dental x-rays that you are doing, you can refer them back again. And by this, you might be the reason that the things are discovered and recognized earlier. By this slide, I will come to the final. This is the final slide for my presentation. I hope that I did cover the things in a good way. And now I will be very happy to take your questions, if any. I will stop sharing now.
Thank you a lot, Dr. Safa. We have two questions. First one is in cases where a mixed radiolucent radiopaque lesion is identified, what are your primary clinical red flags for differentiating a benign calcifying epithelial odontogenic tumor from a more aggressive fibroosseous lesion before the biopsy results are in?
Okay, so in this case, I would say if we are having a mixed radiolucency radioopaque area, if we are speaking about other types of fibroosseous lesion, that they have they look not the same as this one. So for this one, we would see that the radiolucency and the radioopaque, they are very well defined. For the fibroosseous lesion, for example, if we are speaking about cementifying ossifying fibroma or fibrous dysplasia, we would see that, طبعا, first of all, we would put the age of the patient in our mind, because always the fibroosseous lesions, they might occur, for example, in if we are speaking about fibrous dysplasia, it's at the age of puberty. And then if we are speaking about cementifying ossifying fibroma, it should be mainly in the anterior mandible. This is one of the things. The age of the patient itself, starting from the history. And again, looking at the clinical examination, because always the lesions which are related to ameloblastoma, they look different a little bit from the, given the fact of the buccolingual expansion that we have mentioned earlier. And the last thing that I would say, that radiolucency and radioopaque will become a little bit different. We can differentiate, by the way, if it's another fibroosseous lesion, or if we are speaking about ameloblastoma versus the calcifying epithelial odontogenic tumor that I mentioned earlier. I'm not sure if this answer would give an appropriate answer for the student who asked, but I think showing both radiographs and at the same time showing him the thing that I'm speaking about would be more beneficial. Yeah.
Thanks a lot, Dr. Safa. And
Thanks.
the second question is, with the shift toward more conservative treatments in some areas of oral surgery, how do you determine the threshold for choosing inoculation with curettage over a more radical resection for a multicystic ameloblastoma to ensure the lowest possible recurrence rate?
The idea will be, or the thing that will give us the most judgment in this case, is the size of the tumor itself. So when the tumor is from the beginning, like it's a very large tumor, and even we would, for example, look at the mandible. If the tumor within the mandible, how much part of the margin of the mandible, the lower inferior mandible margin, how much is left from it? So if it's already like we have like 2 millimeter, or then this is an indication for an invasive and a very big resection. The idea when we will shift to invasive is the early detected lesion, which are very small. They are not like taking part of the inferior part of the mandible or the posterior part of the maxilla, if you are speaking about the posterior maxilla. So it depends on the size, I would say. Size, and also the evaluation of the adjacent structures. Yeah.
Thanks a lot, Dr. Safa. Dear Dr. Safa, on behalf of the IADS Score Webinars team, we would like to express our sincere gratitude for the incredible session you delivered today. Your insights and expertise on odontogenic tumors were truly valuable to our global dental community. The engagement from the participants speaks volumes about the quality of your presentation, and we are honored to have had you with us today. We look forward to the possibility of collaborating with you again in the future. With best regards, IADS Core Webinars team. Thanks a lot, Dr. Safi.
Thank you so much, Dr. Adham. Thank you so much.
Dear participants, we have the attendance and feedback form. We are asking you please to register on it.